Let's get started. So we're going to do part two now. I've already set up a section for part three. So I have a goal of what I'm going to try and get to. I think this is going to go through ST elevation will be the plan. So as you recall, just as a brief review, we kind of went over rate rhythm axis. Then we started into the P wave. We got into what you can use to decide if there's left atrial elevation, right atrial elevation, looking at V1 as well as leads 1 and 2 as well. We talked about the axis and using the leads 1 through 3 as well as V1 through 5 and 6 to kind of help you with that. Dr. Duffy kind of talked about it as well yesterday, which was a good refresher for you all. And then we got into very briefly the atrial pace rhythms, just being able to identify when you see that pacer spike, just knowing that it's going to potentially create some artifact on there. And if it's a V-pace rhythm, which we'll get to later, it can create what appears to be a junctional rhythm. So let's go over PR intervals. The normal interval is going to be 120 to 200. So just look for anything less than 200. Once it has reached that great peak of 200, then we know there's going to be some kind of block that we're potentially dealing with, right? And I thought this was a nice flow chart to kind of show you how to decide between the two. Like constant interval is always going to be is going to be either the first degree or a second degree type 2, whereas a variable PR interval is going to be where you have the Wiekebach, the type second degree type 1, where it's progressing, and then it drops. And then we'll go over how to kind of help identify if that's happening versus a third degree where there's really no association at all. As a result, that PR interval can change and it looks like it changes. You can see that appearance here because of the fact that the QRS and the P waves are not associated with one another, that whenever they just happen to beat or get triggered, that PR interval is going to end up changing on both. So you can divide again between constant and variable. That's going to help you also when you get into your ACLS, when you get your renewal. Kind of those are the common rhythms that seem to be missed. So first degree, simply just a prolonged rhythm. So this is an example of a first degree AV block. You can see that PR interval does not appear to change over time. So pretty simple, first degree. Very common. They're not going to be dangerous. They're very benign rhythms that we notice in patients incidentally, typically in the hospital. Secondary type 2 is your Wiekebach. Again, that's going to be your progressively long, elongating PR interval until eventually one of them is going to be dropped, right? We don't typically treat these, right? We know that the secondary type 2 and your third degree are the ones that we really get concerned about because of the progression or deterioration that could eventually happen leading to VFib. But if someone is symptomatically bradycardic and they have a secondary type 1, some cardiologists will recommend pacemakers for those patients. So let's look at the secondary type 1 example. This is from learningtheheart.com, as you can see clearly in the background of the EKG. The best way to really kind of decide, so we'll kind of focus on this section right here. And you can see that the PR interval is pretty short. Right after, we'll wait for a pause, and then we'll look for the PR interval, and then we'll look for right after the pause. So in this one, it's probably not the best. It's easier to use my method when you have like 3 or 4 before the drop, but you basically compare the PR interval that occurs in the QRS complex right before the drop. And you can see the drop happened here. There was a P wave that just didn't conduct. And then you compare it to the PR of complex right after the drop. And so basically the PR right after the complex is going to be the shortest possible. And the PR complex before the drop is going to be the longest because it eventually elongates longer until the drop. So in this one, it's not as easy to see. Let me clear all that ink out so you can kind of see over what I wrote there. But you can just see that over time, it's going to elongate before it drops. And again, in secondary type 1, if they're symptomatically bradycardic, you can treat those. Otherwise, you don't have to. And then we can get to our type 2s. So this is going to be where there's that constant PR interval. But it's not going to be technically one-to-one with the QRS, which is why it's dangerous and why we know that there's clearly some dissociation happening at the AV region between the PR or the sinus node and the AV node, which is why we want to treat these patients because of the risk for them deteriorating. It does represent some disease. There has to be some disease at the AV node, which is what we're worried about. And it can lead, again, to potentially a third degree AV block and then eventually ventricular fibrillation. So these patients, I don't think it's going to be completely rare to see them. Do you only treat AV blocks at bradycardic? No. So even if they have second degree type 2, you'd still treat it, as well as third degree. If they're type 1 and they're bradycardic, I don't think I've seen personally a cardiologist treat those. But if they're second degree type 1 and we know that's not a dangerous rhythm for progression to third degree, but they're bradycardic, that is an indication to get cardiology involved to see if you think, or if they think a pacemaker is indicated. So hopefully that answers your question, Chase. So in these patients, it's not uncommon to see them in the hospital. So you will want to, if you're on your own or if you don't have a cardiologist nearby or a fellow, you want to get the temporary pacing leads there. It is painful, so you're going to require some kind of sedation for this patient, whether it's a slight touch of Ativan. This would be a clear indication to contact the on-call physician for us so we know what's going on. And then if they are not already, you'd want to move them to a cardiac floor, if not to the ICU. These patients, I think it'd be very reasonable to let the ICU know since they have a critical care or a cardiology specific ICU. But they don't always move all these patients, but in not all the hospitals you'll eventually work at will have a cardiac specific ICU. So I know as a resident, I've treated these patients just on a regular medical floor, just as long as the nurses are comfortable with it. So here's an example of a secondary type 2. So what we can see is that this PR interval from here to here appears to be pretty consistent all the way through. So we know that this is not going to be a third degree and it's not going to be a second degree type 1. So it has to be either a first degree or a second degree type 2 if we use that flow chart from the beginning. You had a block on a patient earlier this year with you overnight. I did. Probably. I don't remember. My memory doesn't go back that far, Pat. So it's the dementia kicking in. So you can see that the PR intervals appear to be pretty goldfish. Is that the name of the patient? Or are they eating goldfish? Or do they hate goldfish? No memory. Goldfish don't have memory? Oh, okay. All right, I didn't know that. I thought maybe that was the name of the patient. I was like, I would have remembered that the patient's name was Goldfish. So you can see the PR intervals are pretty consistent. So this has to be either that second degree type 2, or we're going to be dealing with a first degree. And the fact that there's clearly a gap going on, then we know this is not going to be a first degree. So this has to be a second degree type 2. So again, in these patients, this is probably the easiest way to kind of help decipher it not only in a quick manner, but also on your ACLS exams. Just use that kind of method. Now I'm hungry for goldfish. Chase, honestly, you're always hungry. You eat like 3 lunches every day. And you can't do complex jokes with aging patients. I'll remember that, Mirzakani. Thanks. Second degree type 2, here's another example of it. So again, we're looking for that PR interval. We can see here's the PR interval right here, a good one. And if we compare it to what appears to be a pretty peaked P wave, maybe this person has some LAE at the same time. It's consistent. And the fact that we see clearly some beats that didn't conduct, this can't be a first degree. So this can be a second degree type 2. Then I'm going to, Pat, you're asking if I'm going to hold it against her. Oh, I will. I hold grudges. They don't leave. So, all right. Third degree blocks. These are bad news bears, right? You don't ever want to see these. There's clearly not going to be any association between the sinus and the AV node. I think these can be somewhat difficult sometimes to see, right? If you remember the M&M from 2 weeks ago, yeah, I guess it was 2 weeks ago. Some people thought that it was a secondary type 2 versus a third degree. Luckily, the management is the same, but you're going to see what appears to be a pretty consistent rhythm. And that's what makes it easy to decipher. But the PR interval is not going to be consistent because if you recall from the previous slide, what I mentioned is based on whenever that AV node decides to conduct the QRS, that PR interval is going to vary as a result because they're clearly not going to be associated with one another. So, but if you look at the Ps themselves, maybe there's a way I can draw on here and kind of translate it across. I don't know, but the Ps will clearly march out in a rhythmic manner as well as the Rs. That will not happen in a second degree type 2. So for some reason, you don't know if it's a second degree type 1 or 2, even though both these patients need to have pacing on. You could do that, but I would argue just get the pacing on at the same time. But they're going to be different rates. So the P is going to be a lot faster than the R are going to be, which shows that there's clearly some dissociation happening. So let's look at an example of a third degree. So first, let's use the PR intervals to kind of help us. So we have a PR interval here, we have a PR here, and already we can see this is not going to be consistent or at the same distance. So it can't be a first degree or second degree type 2. So we're dealing with either a second degree type 1 or we're dealing with a third degree. So if we looked at, for example, here, we see it's long and then it got longer and then it maybe dropped. There's like a P here, but then it got short, long, but then it dropped again. Like it wasn't consistent, whereas even with a second degree type 1, you're going to have the same rhythmic. If it's every third beat, you get the prolongation, the drop. That wasn't there. So now you know this can't be a second degree type 1. But if you looked at, let me erase all this stuff here. And I don't know if I can draw, yeah, I can't draw a line on here. But if you were to look at this P to P here, it looks like, actually, it looks like it's probably out to this point. And then you have P to P here. Looks like there's a P superimposed, if not maybe like hidden right there. And then we have a P to the P there. You can look at each one of these lines and you can see that they seem to be somewhat consistent in terms of their length. And then you can look at the R's. And if we looked at the R's on their own, they look to be consistent too. So the fact that the R's to R's match and then the P's to P's match kind of helps you also decide this is a third degree block. But you have these intermittent non-conducted beats that are happening sporadically, which also is kind of like that harbinger for this being a third degree AV block. And it looks like there was probably even another missed beat here where a third P wave is present, but it never conducted. And then another P kind of just shot on again. So there's clear chaos happening on this EKG. That's why you want to get that pacemaker involved. So that's the PR intervals. In short, we talked about how they should be less than 200. When they're greater than that, we have first degree through third degree. We can use the PR intervals and their consistency or lack thereof to kind of help us decide which one are we dealing with. Are we dealing with a third degree or a secondary type 1 where they're going to be inconsistent versus a first degree and a second degree type 2 where they're going to be consistent. What questions you guys have before I go on to Q waves? None. All right, let's go on. So Q waves, it's the first downward deflection after the P wave. So it's easy to miss Q waves if they're not very obvious. Even if you see just a small little downward deflection, even if it looks like it's the dot of a pen, that counts. But it's not necessarily like clinically significant Q wave. All right, so let's look at some Q waves here. You can see that on 2, 3, and AVF, it looks like this patient probably had a prior MI. We can see that, let's see, so here's the P wave, and then we can see the first downward deflection is a Q, so this is definitely greater than 1 box wide and deep. And then we see another P here, and then we see another box deep, and then a P, and then the first downward deflection, right? So if there wasn't a downward deflection after the P, then, and if you just had the R and then an S, then that S is going to be its own S because it happened after the R wave. All right, so pretty simple. Why do we care about them? Because while normal individuals will have very small and many, but not all EKG leads, they are pathologic, right? We're concerned about old infarcts happening. If we had someone that's maybe transferring from an outside center and maybe they, for some reason, didn't do TPA or they weren't able to recognize on the EKG that this person was having an active STEMI, then by the time they get to you, maybe you're going to see some Q waves and wonder whether or not there's actually any tissue that's reversible that you could act on. Any leads that you notice, or any Q waves, I should say, that are present in 2 and 3 that are greater than 0.02 seconds, so seconds, not milliseconds. So 0.2 is going to be for one big box, and then 0.04 is going to be for each individual. Then you know that there's going to be some pathology going on with that. But the Q wave has to be that basically bigger than 1 small box and 1 big box deep is for the most part is like the generic recommendation for it. And you should see some kind of contiguous leading, which will tie with the anatomy that Dr. Duffy talks about. So meaning you see Q waves in 2, 3 AVF, like we mentioned on the previous EKG, maybe in 1 in AVL, maybe V1 and 2 on their own, maybe V5 and V6, but you're not going to see, you shouldn't see one in leads 2 and then lead V3. Like that wouldn't be concordant with an anatomic association. I put some extra information about the R wave, being greater in the S and V1 and 2, and it can help with deciding if there's a conduction defect happening. Don't worry about that. I just try to make these as thorough as possible if you were ever pimped on your cardiology rotations about Q waves. So I'm not going to go into them in depth because I really want to try and finish at the time that I was hoping to. But one quick method to remember, though, is a Q wave that is greater than 1/4 the length of the following R wave, or at least 1 box wide, is going to be pathologic. So again, I use a 1 box wide method, but you could use greater than 1/4 the length, the width of the R wave would be also pathologic. So let's go into QRS. So that's the most I put in there. There's really no need to go too much into Q waves. You can see, oh, sorry, skipping all over the place. You just need to know again. So what they're saying is the length of this is greater than or 1/4 the length of the QRS. You could use that, or you can use the 1 box wide, 1 box deep method as well. QRS. So, and then one quick thing on the Q waves, I wouldn't want you in that clinical scenario, like I said, with that patient to say, oh, they have Q waves, so there's clearly nothing we can do. I'm not going to call cardiology. You should still call them and say they have some development of Q waves, which were not present on the EKG that was sent prior to transfer of the patient. So you would still treat them all out and then let the cardiologist decide if they're still going to stent or not, depending on, or cath, depending on what they see on the EKG. So QRS, this is where a lot of the I don't want to say pathology, but a lot of the information kind of where this slide or this slide deck becomes very thorough is with the QRS complex, because there's so much that happens within this, things that we know and things that sometimes we haven't even seen before that I'll show you today that I've learned over the past few months. So I try to make this section especially thorough on top of the segment elevation section. So as we mentioned earlier I guess it was earlier this week, the QRS is going to be that ventricular depolarization, whereas the pure interval should be less than 200 milliseconds or 0.2. We want this QRS to be at least less than 0.12. When it gets less than 0.1 or greater than 150 milliseconds is where it's truly going to be going into your bundle branch scenarios. When it's 120 to 150 milliseconds, that's where it can be like an incomplete bundle branch block. So just know that they should theoretically be less than 0.12 seconds or 120 milliseconds. There's clearly three components. So you're going to have the Q wave, which again, as I mentioned, the first downward deflection, the R wave, and then the S wave. So this is something that I learned just probably like 2-3 months ago. Maybe I should have known it before, but I clearly didn't. It was brought up by one of our medical students on an EKG, and he had mentioned, I think his name was Taylor. He had mentioned on a EKG on our patient that he saw this little bump, kind of upward positive deflection after an initial negative on a patient. And honestly, I was like, I don't know what that represents. Let me look into it. So I looked into it, and this is very interesting. It can be a harbinger or preceding patients that actually have cardiovascular disease. It doesn't mean that there's a timeline associated, meaning that if you see this, oh my gosh, you need to get them in the cath lab now. No, it just means that maybe if you saw this and you had a patient that potentially didn't want to be on a statin, they were high risk otherwise, you could use this as a reason like, hey, I'm already seeing some changes on your EKG that would suggest that you have a higher chance of progressing or not only already having silent ischemia or disease, cardiac disease. Maybe we should do the statin. So this would be a way that you could use that. Or if you have someone who has non-specific symptoms and you see this in the EKG, you could bring that up maybe with cardiology and ask them about that. I know, right? You like that harbinger word? I'm going to keep using it throughout this presentation to the point where you guys are going to get annoyed by it. Yeah. So this was an actual case I found in a patient. I think I put this in page 55, at least I said I did, of your handout. And we have a nuclear study on the right side, which I think I actually got to that on our cardiac diagnostic testing PowerPoint, which I will finish, by the way. But what we saw was on our or EKG on this patient, we saw that it looks like they had something here, maybe as well here, but they had, and as well as AVF. So they had this fractionation or fragmented QRS complex, and it was in a 65-year-old. This person already had an old MI. I don't see Q waves here. So it's kind of interesting. They don't have any Q waves. I wouldn't call that a Q wave because you can see this little dot right here that is more suggestive of an R. So that is what appears to be an S instead. But in this patient, the 12 lead didn't have any abnormal Q waves. Multiple R waves were present, 3 in AVF. And when they did the nuclear image and they showed a fixed myocardial diffusion defect. So again, this can be suggestive not of active disease or something that's clinically significant, but it could be suggestive of a patient that potentially already has disease there that warrants intervention on. So just know about fragmented QRSs, because I thought that was very interesting and I immediately added it to this PowerPoint when I learned about that. So let's now talk about bundle branch blocks. This is going to be a little prolonged because I'm going to go into both your left bundle branch blocks as well as your right bundle branch. So again, we're thinking about things that are greater than 150 milliseconds. So if it's 120, you can consider potentially this being an incomplete bundle branch block. So your right bundle branch is going to be your rabbit ears, right? So here's one ear of the rabbit, and then here's the other ear of the rabbit, or it's called the RSR. So that nomenclature, if you don't already know, it's because this R is low, it looks smaller than a second R, so we make it lowercase, and then the second R looks taller, so we make it capital. So that's where that RSR prime denomination comes from. And then this is clearly going to be an S wave because it's the first positive deflection after the P wave. And there's no Q waves in this one. So it's normal. Oh, sorry. So normal left to right ventricular depolarization occurs, but it just takes longer, which results in the right side appearing of, sorry. So if you have a right bundle branch block, then basically what happens is you have depolarization and electrical activity going to the left side of the heart because it has to basically bypass that right side because it's not able to get to it directly because of some ischemic disease present. And then eventually when it gets to that right side, then it creates this upward deflection. Or this upward deflection here. And then, so this is the left, this is the right. Acute severe occlusion in LAD can present with a new right bundle branch block. Why did I put that there? Because we've always studied that left bundle branch blocks that are new are concerning to us. And I think it was back in like 2012 to 13, there was a lot of, 12 to 13, because I remember it was right in the beginning of my residency, that there was some suspicion about whether or not we should still consider left bundle branch blocks as bad as an ST elevation. And you will still see people continue to get concerned and treat them and get cardiology involved. I think a lot of us didn't really consider right bundle branch blocks, but just remember, if you have a left anterior fascicular block, which we'll get to later, as well as a right bundle branch block, you should be concerning for LAD occlusion. And any elevation in an ST segment in V1 and V2, so this would be the ST segment right here, with a right bundle branch block should be concerning for true ischemic disease. So let's look at what an LAD occlusion would look like in that scenario. So again, I mentioned in this yellow, if you had a new right bundle branch block with a left anterior fascicular block, then it's suggestive of LAD occlusion. So in this patient, I probably should have put this after I discussed the left anterior fascicular blocks, but here we can see that, so V1, the QRS starts here. That was supposed to be a straight line and it wasn't. So it's clearly prolonged. It's going to be greater than 150 milliseconds. So we know this is a true block. And then we can see that it's very subtle, but it looks like there's somewhat of an upward deflection and then a down, and then the second rabbit ear is right here. So, and you can actually see it a little better in V2 as well. So we see what appears to be a right bundle branch block. And then we look at 2, 3 in AVF, and we can see that there's deep S waves. So that's what's going to help you decide or be concerned about a left anterior fascicular block, is that 2, 3 AVF with deep S waves, but we'll get to that later. If we were to look at the axis, this is a difficult one. I don't know if I'd call that positive, and then this is clearly negative. So it looks like it's probably a left axis deviation. But in this one, we can see there's a right bundle branch block. We can see in a left anterior fascicular block with a prolonged QRS and a deep S waves present in 2, 3 AVF. And those two together might increase your concern for a left anterior descending occlusion. Here we can look at the ST segment as well, because remember I said if you have ST elevation with right bundle branch block in the V1 or 2, it's not normal. And we can see here, it looks like there's an ST elevation there as well as there. So that's just an example of an EKG, not just showing you the text, but showing you an EKG that kind of corresponds with what I just kind of told you guys. So let's go over the anatomy of a right bundle branch block so we can understand what's happening. So obviously we have the AV node, and then when the AV node gets depolarized or activated, it's going to then transfer electricity down the right bundle branches, and then it's going to go through basically the Purkinjes. So the conduction of the bundle to the right ventricle is slow. As the right ventricle depolarizes, that left ventricle is pretty much halfway finished, and it's going to counteract the electrical forces to the left. So the last electrical activity is due to the right or towards the lead V1. I'm reading this so just to help you out, and then we'll explain it. And in right bundle branch blocks, the QRS complex in V1 is always markedly positive. So again, what's happening is you had some occlusion. I put this red X there. So instead of electrical activity being able to go down and they continue all the way down to eventually depolarize the rest of this right ventricle, it's blocked. It's not able to. So it's going to take a lot longer. So instead, it's going to go through the left ventricle. It's going to depolarize everything. And then it's going to eventually make its way across to the right side. But because of that long delay that was created because of some ischemia, then you see this extra flip go up positive. Yeah, my mouse, I blame the mouse. I tried to draw over that, but it was completely off. So hopefully that kind of makes sense. You can see that the disease is on that right side, which is why it's called right bundle branch block. So the electrical activity can preferentially go down the left, but then its ability to eventually go to the right side is going to be delayed because of that disease, resulting in that rabbit ear appearance. So what's the criteria? Technically, it just needs to be greater than 120 milliseconds, because then you would be saying like an incomplete, but most people say 150. You're going to still have that RSR. I should have had a lowercase r. I think it was probably auto-corrected. Oh, you can't see what I'm drawing? Oh, well, I don't know if that's good or bad at all. Guys waited until like the 5th slide. Okay, so you can probably see that then. All right, well, I will, I'm not going to go back, but I don't think you guys missed anything. That's lame. Can I even clear mine now? I can't even clear my drawings now. Mina, I blame you on this. Let me see. Erase all. Let me draw. Let me find out how I can draw. Okay, can you guys see this? Is it not in presentation mode? Are you guys only looking at my PowerPoint? Oh, well, that was not intended. Okay, I've been drawing on the presentation. All right, let me, yep. Did I completely screw it up? Oh yeah, all right, Pat's showing me. All right, here, can you stay in here? Let me change it to, there we go. Okay, now it works.
I didn't realize you were drawing anything.
All right, well, I was drawing fantastic things. You guys missed all of it. So now you can see of it. Okay, cool. Yeah, we're not starting over. Probably should, but you guys didn't miss anything. I was kind of just highlighting certain areas, but I don't think it was that big of a deal. So clear all my drawings. Okay, just to make sure, can you guys see what I'm drawing right now, that little shell? Okay, cool. So let me erase that then. All right, so now, we talked about right bundle branch block. What we said is you have an RSR prime, you have a rabbit ear appearance. We're looking for that in V1 and 2. If you have an ST elevation in V1 and 2 with a right bundle branch block, that's never normal. You're thinking of ischemic disease. If you have a new right bundle branch block, I would suggest and argue that that's also not normal, but especially if you have a new bundle branch block with a left anterior fascicular block, which you'll see in 2, 3, and AVF with deep S's, then you should be concerned about a complete occlusion of the LAD. So let's talk about left bundle branch blocks. Another way to kind of remember these is if you were to take an EKG looking straight at you and you rotate it 90 degrees clockwise so that the EKG is now on its side, if you look at the direction of what this block is pointing, it's going to point towards the direction, or the QRS complex is going to point in the direction of the block. So if I were to rotate this image 90 degrees, I don't want to screw up with that. Actually, let me see if I can share a different screen to kind of show you what I'm talking about. So now you should see this screen. So if I were to rotate this 90 degrees, now this QRS complex is mostly pointing to the left side. So that would be suggestive of a left bundle branch block. And then if we were to go back to the right, if I were to rotate this 90 degrees, you can see the QRS complex for the most part is pointing to the right side. So that'd be a right bundle branch block. I don't recommend you use that as your primary method for determining these, but it's just something to remember. So let me just go back to sharing the PowerPoint. Okay. So in a left bundle branch block, it's gonna be a negative deflection in V1. There's that loss, that normal left to right depolarization, because again, you're gonna see that the left ventricle depolarize and then the right ventricle, but because now that block is affecting the left side, it's gonna depolarize the right side first, and then it's eventually gonna depolarize the left side, which is gonna result in the appearance that we're gonna see, and we'll talk about that. In these patients that have a left bundle branch block, you're gonna consider cardiac disease, AV disease as well at the AV node, as well as cardiomyopathies, whether it's ischemic, tachyarrhythmic, or dilated, et cetera. So let's look at the anatomy of the left bundle branch block. So I'll read this to kind of help out. Its conduction to the left side is going to be slow because as I put the X here, you can see that the disease is going to not allow that electrical activity to pass down this current. So there's a delayed depolarization of that left ventricle, especially on that left lateral wall, because this is the farthest away from it. So the electrical activity in the left lateral wall is unopposed by the usual right ventricular activity because it's basically on its own. So the last electrical activity you see on the EKG goes to the left or away from V1. So what happens is, you remember V1 is going to be, if I were to draw a person's chest here, and we have the heart's activity going from left to right, we know that V1 was on the right upper sternal border, the left or third intercostal space or so on the right side. So it should be that the electrical activity is going away from it, and it is. So it makes sense that V1 is going to overall be a negative deflection. But what happens is that because we miss out on the ability to go and depolarize the left side first, the heart initially goes to the right side. It's going to help get the rest of the right bundle branch block. And then eventually it's going to make its way to the left side as it's able to bypass that occluded bundle branch block. So you can see this electrical activity will start on the right ventricle, and then it's going to make its way eventually across to the left, which is what causes this initial positive deflection. Because of V1, if you kind of imagine V1 being in this direction or in this side, if the activity is going to the right ventricle first, it's going to go towards V1. So then it's going to cause that initial upward deflection. But then once it eventually makes its way down to the left ventricle, then it's going to cause that negative deflection because now it's going away from it. I'm spending time on this because for me personally, seeing things makes more sense than just memorizing it or saying, okay, if I rotate to the right side, then if it's pointing to the left and stuff, well, why does it look like that? I think that's more interesting in general. So hopefully that explains why you see the left bundle branch block the way you do. So the criteria for it, again, greater than 0.12 seconds. Some will say greater than 150 milliseconds to become complete, but technically it's just greater than 0.12. It's going to be broad. You're going to have that notching of the R wave in V5, 6, and even one in AVL. So the R wave, let me see if I kind of rotated it here, but you can see how there's a little notching. So you can sometimes see a notching in the low lateral leads of V5 and 6. You'll see some ST segment depression and T wave inversions that can also happen because, you know, they're describing the disease that's already present at that left ventricle, left bundle branch blocks. You're seeing reciprocal changes, which you can see here with a T wave that's got inverted, a T wave that got inverted with some ST depression that happened as well. And you might see some reciprocal changes in V1 and 2. Left axis deviation is very commonly present. It doesn't have to be present, but in most instances, you're going to see I don't want to say LAD because I don't want you to think it's left anterior descending, but you can see some left axis deviation as well. So let's review very quickly the right bundle. We went over just bundle blocks in general. We said the right bundle branch blocks, we have disease on the right bundle branch, which causes depolarization to happen to the left first. As a result of that depolarization happening to the left first, we're going to have that deep negative that's happening. And then once we're eventually able to get repolarization to the right side, then we see that second bunny ear happen because, again, it's going towards V1. Whereas the left bundle branches were completely different. Since the left bundle branch was blocked, we have activity first going towards the heart, or towards V1, I should say, causing that upward deflection. I'll kind of draw over here. And then once it eventually made its way to the left side, then it caused that negative deflection. So that kind of explains why you see what you see. So let's go with some of these other blocks. The fascicular blocks or heavy blocks is where we're going to talk about the left anterior and the left posterior fascicular, which I kind of alluded to with the right bundle branch when you have patients are concerned about potentially having a complete occlusion to LAD. So again, they're also called hemi blocks. I put that term in there because depending on what you type into Google, you'll find both referred, or this referred to both of them. Normal anatomies for the left bundle branch to divide into the anterior fascicle and the posterior fascicle. So you can see the left anterior fascicle is going to be right here. And then the posterior fascicle is going to be up here. So this is disease that's happening to these specific fascicles that can generate activity or pathologic signs that we'll see on the left side of the EKG. So when a left bundle branch block is, so a true bundle branch block that we just talked about, then if you go back, we said that the disease was high up here. So then both of these anterior and posterior fascicles were affected. But if not both are affected, then you can see just a left anterior fascicular block or a left posterior fascicular block. So left anterior fascicular block was sometimes called extreme left axis deviation. It doesn't happen commonly, about 2.5% of the population. Remember the association with your right bundle branch blocks for the complete occlusion of the LAD. If you see a left anterior fascicular block with that LAD, start looking for an old MI. Maybe you'll see some Q waves present. Maybe some LVH. You can see pre-excitation with a J point elevation, or not pre-excitation, I mean J point elevation, pre-excitation with like a Wolff-Parkinson-White, or just underlying pulmonary disease. There is some suggestion that having LAFB could be a marker for late onset AFib. So someone who maybe has, didn't mean to hit that. Maybe has high the risk factors for AFib. They have OSA that's untreated. Maybe that an echo that's previously done and you already saw some left anterior dilatation. But if you see a left anterior fascicular block based on this cardiovascular health study where they followed patients that had it and they found this association, then you can consider that just a nugget of knowledge. So left posterior fascicular blocks are going to have the opposite. They're going to have the right axis deviation. That's going to be at least 90 degrees. I'm not going to go over the axes again because we did that for the entire last lecture. It's definitely more rare. And it's more rare because it has two different areas of blood supply. So you'd have to affect both of those areas of blood supply to truly, and I'll go back to the anatomy. You'd have to affect both areas of blood supply to get a complete occlusion of this fascicle. So that's why it's just not as common. But it has very similar differential diagnoses with the Wolff-Parkinson and old MI. But in this side, especially, or in this differential, we're going to have RVH versus LVH, which makes sense because of the RAD that we're going to see that associates with it. So let's look at the left anterior fascicular block. So it's going to have a QR pattern. So what I mean by that is you're going to look at 2, 3, you're going to have the QR pattern is going to be one AVL, but to make a diagnosis of the LAFB, look at 2, 3, and AVF. Here you're going to see that it's going to have very deep S waves. So deep S, and then deep S. So the deep S is going to be at least 150 milliseconds. You're going to see with potentially with the duration of the QRS as well is suggestive, or this RS pattern is suggestive of left anterior fascicular block. If you looked at one in AVL, it's also going to have the QR appearance. So you can see a Q wave here, you can see a Q wave there, Q wave there. So you're going to have just a pure QR with no S. So the S's are going to appear in 2, 3 AVF, but the S's are going to be invisible or non-apparent in 1 AVL. I put these specific timelines just to be very unnecessarily specific for you guys. Again, if you want to study and use these for when you're doing a cardiology rotation, but it's really not necessary from a general internist standpoint. This will also, left anterior fascicular block will typically be associated with left axis deviation, which we see here in 1 going upwards and leads AVF going downward. So they're leaving each other. So it's clearly a left axis deviation. But remember, left posterior fascicular block, you're more likely to see a right axis deviation. We're going to see complete kind of opposite mirroring where you're going to see the deep S's in 1 AVL. So remember, left anterior fascicular block, deep S, 2, 3 AVF, and then you're not going to have any S's in 1 AVL. Instead, you're going to have a Q and an R wave on their own. Let me hide something here. That something from Zoom is kind of over. There we go. So in a left anterior fascicular block, remember, you're going to think of left axis deviation. For a left posterior fascicular block, we're thinking of right axis deviation. So this kind of summarizes the same thing I just showed you on the other slide to show you that with that deep S's that we're seeing in 2, 3 AVF, the absence in 1 in AVL is suggestive of a left anterior fascicular block with the appropriate left axis deviation. So let's look at left posterior fascicular block. So as I mentioned, it's kind of opposite in a way. So where in 1 in AVL, we saw that it was clearly a Q and then an R. In 1 in AVL with left posterior fascicular block, we're instead seeing an R and an S. So now that S comes back. So S is going to appear in 1 in AVL. And then when we look at 2, 3 in AVF, it's basically, again, a reversal. You're seeing a QR now in 2, 3 in AVF. So the RS was present in 2, 3 AVF, and then we saw QR present in 1 in AVL and left anterior fascicular block, and with left posterior fascicular block, it's the reverse. These patients are going to, as a result of having just that QR complex, they're more likely to have a right axis deviation. So if lead 1 is pointing down and lead AVF is pointing up, they're returning to each other. So then it's going to be a right axis deviation. The QRS duration, again, is typically going to be less than 120 milliseconds. You're not going to get to that 150 that you would see with pure bundle branch blocks, left bundle branch and right bundle branch, because again, you're not having all the fascicles involved. You're just having one or the other. So this is showing the exact same thing, just a different way of looking at it from a graphical color standpoint. If you looked at 2, 3 in AVF, we can see that QR shows up, whereas with the 1 in AVL, we see the R and the S. Seems pretty simple. I just didn't feel like a lot of presentations on EKGs, in my experience, kind of went into the hemi blocks or fascicular blocks. That's why I want to do that for you guys and just go over the differentials. So let's take a look at this EKG. I'm going to have someone kind of point out, what do you see in terms of axis? Is this a normal axis? Does this look like a right axis or a left axis? Yeah, so it looks like a left axis deviation. And then if we looked, since we're in the fascicular block section, we already know though that it looks like there's an appearance of a left bundle branch block here. We don't see the rabbit ear, so we know it's not a right axis right bundle branch block, but it definitely does have the deep S in V1, V2. It looks like there's some reciprocal ST elevation in there just to kind of keep an eye on. But then if we looked at 2, 3, and AVF, since we're in the fascicular block section, let's look at 2, 3 AVF. We can see an R and an S. So here's an R, 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 and then we can see the corresponding S, S, and S. So in 2, 3 AVF, we have the S waves there. And then if we looked at 1 in AVL, we have the QR. So here's that big R and then a big R there. So what type of fascicular block would you think is going on here? A left anterior or a left posterior? Anyone? Yeah, great job, Gracie. So it's this looks like it's more suggestive of, oh, I forgot I put the cool animations in. Left anterior fascicular block. Let's do another one. So we see this looks like it's a right axis deviation. We have the R wave or QR, the S wave returning in lead 1, and then we have the R wave returning in AVF. So they're coming to each other. So it's a right axis deviation. We have QRs in 2 through AVF, whereas we have the S waves, or S waves, I should say, in 1 in AVL. So this would be what type of block? What's the other one other than left anterior? Basic, there we go. Yeah, so this is a left posterior fascicular block. So the right axis deviation not only helps you, because remember I said left axis deviation is going to be most commonly present with the left anterior fascicular block, but you're going to see deep S's in 2 through AVF and left anterior fascicular block, whereas you're going to see deep S's in 1 in AVL with left posterior fascicular block. Was that last one alternans? Let me look back. Yeah, it kind of looks like it, right? I mean, it looks like it kind of, I don't know if I'm accentuating it though. It looks like it has an alternans appearance. The next thing I would look at to see if it, fits it is the overall voltage. So I have the calibration box. It is about 2 big boxes, so it's an appropriate one, but I don't see anything that looks like it's low voltage. So it might be that it's the breathing rhythm of the patient that's making it look like it's alternans, but it doesn't have any other appearances that would be consistent with it. But I think that's a good catch. All right, let's do another one. So we see positive in 1, negative in AVF. So it's a left axis deviation, S wave in 2, 3 AVF, and the tall R's in 1 in AVL. So what kind of block is this? What's fake news? The existence of left axis deviation or the existence of electrical alternans? Answer me, Max. All right. Yeah, so original Max 2 days in a row. Yeah, I know, right? I don't know if we can handle that. Don't want to. So yeah, this is a left anterior fascicular block. Great job, Gracie. So bifascicular blocks, these are when you can have a right bundle branch with either a left anterior or left posterior. If you have a right bundle branch with which one of those would be concerning for a complete occlusion? Anyone? Right bundle branch with what is not circumflex, which block? Yeah, so with the left anterior fascicular block is suggestive of complete occlusion at LAD. Incomplete trifascicular blocks, right bundle branch with one of the 2 above, as we mentioned, with the 1st degree. This is not really common, but I've seen it, I think, 1 time before. And these patients have high risk for progression to complete block. So you should do that urgent consult and put them on temporary pacers. If they're on digoxin, this would be a reason to consult cardiology to decide, do you think they need digifab or do you need to reverse that medication? As Dr. Seeker mentioned yesterday with his hyperkalemia talk, you might see this with hyperkalemia. So instead of jumping to consider this is an ST elevation, as he talked about in one of the cases, maybe you need to reverse the hyperkalemia. And this can be seen with ischemia as well. So more on QRS. I just put that placeholder because this is becoming a long section. So we can see, so this section is just a hodgepodge, which is another SAT vocab for you, Neil, of other things that you can see on top of the fragmented QRS, as well as the bundle branches that can cause abnormal appearances to QRS complex. So the delta waves, we all know about that. You don't want to miss that in your young patients, because if you put them on a beta blocker, you're probably going to kill them, because, well, if you put on a beta blocker, you know what to do. You're going to put them into VFib. So it's consistent with pre-excitation. Think Wolff Parkinson White in a young patient who especially collapses, has a syncopal episode. You're going to look for this slurring of that wave that's suggestive of a delta wave. An Osborne wave is kind of the opposite of the fragmented, which initially appeared before the R. So you saw the fragmented on the left side of the QRX complex here, whereas the Osborne is going to appear on the right side. The boards like to ask you this question, and it's always going to be a homeless patient who's an alcoholic who passes out on a city bench, right? I think there's just too many city benches apparently out there for these homeless to pass out on. But every single time they do it, they're going to be hypothermic. They're going to say they have this EKG. You're going to see the Osborne wave. They're not going to ask you about the Osborne wave. They're going to say, what do you want to do? And you're going to replete, obviously increase their temperature as best as you can by heating up fluids. One of the things I kind of learned out in the field in the military was, when you put fluids into someone, that's at room temperature. But room temperature is clearly not 98.7 or 98.6, wherever you think the normal human body temperature is. So you're going to cool them down automatically. So we would use our MRE kits. I don't know if you guys have heard of MREs, but they're meals ready to eat. They are disgusting. They purposely cause constipation, so you don't have to poop when you're on the field, probably too much more than you wanted to know. But they have heating devices that come with them that you mix with water that causes a chemical reaction to heat up the packets so you can have hot food. So we would use them to heat up our normal saline bag. So then when we had hypothermia cases in the field, then we could administer them. So why do I go on the tangent? Just remember that if you're treating someone for hypothermia and you're like, oh, just give them fluids, you're going to actually make it worse. You need to heat that fluid. Are these found in all leads or any particular lead to look at? They're for the most part found in all leads, but you're going to see them as this one mentioned in lead 2. You might see them in 2, 3, and AVF particularly, but the ones that I've seen on the EKG for the boards, they'll have them kind of throughout. But leads 2, 3, and AVF are the ones that we seem to see them, and I don't know why you see them mostly in those beaches, if you're going to ask. Shortbread cookies. Yeah, the shortbread cookies are overrated, man. They're not good. It's when you find the M&Ms or the Skittles, that's when you've hit the jackpot, and then you have to hide them because people are going to go through your stash. And then the Epsilon wave. So the Epsilon wave is going to be kind of an extra bump that you see on the ST segment right there. Very not common, or not very common. Looks like a kind of a fibrillatory wave if you're thinking about like V or AFib, but it's just a fibrillatory or fibrillatory wave that appears in the ST segment. You can think like ARVD in some of these patients, but it's not common. I've never seen it in an actual patient. I've just only seen them on research, but I included it just to be thorough. Okay. So as I mentioned on the last talk, we went over the A-paced or atrial paced leads and EKGs. Let's go over the V-paced. Obviously, the pacemaker is going to be in the ventricle, so it's going to stimulate the ventricular depolarization on its own. You're not going to see much of a P wave on its own. It's not going to be utilizing the SA node for conduction. So you can see these clear spikes here for V-paced. I think on the second part of my diagnostic test lecture, we'll go over the different modes for pacemakers. So I'll leave that for the later talk. But if we're, maybe I'm not leaving it. Sometimes I forget what I've talked about. This is the last slide for pacemakers. So what you can do is if you're trying to find out where's a pacemaker located, you can look at what type of bundle branch block is created on the EKG by that pacemaker. So you can see here, it looks like it was a left bundle branch block based on the V1's appearance with what appears to be the Osborne wave kind of right here, the right side of the EKG. So if a left bundle branch created, the pacemaker is likely in the right ventricle. Because the right ventricle got stimulated first, right? If the right bundle branch block is created, then the pacer lead is in the left ventricle because that got stimulated first and then eventually got to the right ventricle. Or it's at least stimulating through the left ventricle. So maybe they did it through a coronary sinus. So hopefully that kind of makes sense. You can see it in this patient. Let's look for V1. So V1, it has what appears to be rabbit ear appearance. I'd expect that pacemaker is going to be in the left ventricle, whereas we had a pacemaker on the right. Sorry, the Zoom thing keeps getting in the way. But if we had a pacemaker on the right side, we might see what appears to be a left bundle branch instead. So just something quick that you can use to kind of help figure out if you don't know where a pacemaker is, and for some reason you want to know, and you don't have a chest X-ray available to you, then that's one way you can do it based on the EKG and the bundle branch blocks. So that was a very quick review of bundle branches, whether it's a left bundle, right bundle, left anterior versus left posterior, going into even delta Osborne waves as well. What questions you have before I go on to R wave? I will take your silence as that you accept and understand everything. So let's go on to R waves and see if I can finish this in the next 10 minutes. So R waves, again, it's going to be the first positive deflection after the P wave or after a Q wave if it exists. We've kind of talked a lot about this already with the notching, the fragmentation of it as well. So I kind of just brought it up again by putting specific sources. So that fragmented QRS, it's just pretty cool to see. I think you guys will start looking for it after this talk. It's basically a zigzag conduction around some area of scarred myocardium. So when it initially, when it initially depolarized, there was some disease that happened, and then the electrical activity had to go around it. And then by going around it, then it was able to conduct the rest of it. So that's what creates that same appearance that you might see with a bundle branch block. It can give you a marker of ischemia, fibrosis, against scarring, as I mentioned above, even sarcoidosis. These are some good journal articles to read if you want to read more about those cases specifically. It's documented as a lowercase f and then an uppercase QRS. And again, it's an independent predictor for cardiac events in patients because these patients typically have cardiac disease, which caused the electrical activity to have to go around it anyways. It's an indicator of, again, high incidence of arrhythmias as well as sudden cardiac death in patients with ARVD, as I mentioned in the previous slide. You can even see with Brugadas, which we'll talk about later under the ST segment section. And you actually can see, interestingly, some regression of or like reversal of this fragmentation after patients go through some cardiac resynchronization therapy. So again, it suggests that there's some electrical reverse remodeling actually happening by doing resynchronization, that you're able to stimulate the ventricles in clearly a synchronized manner, which is then going to allow that fragmentation to disappear. So that is it on, so we did access. I think we started at PR, we went through blocks, and then I just finished off R, which we kind of talked about with the QRS, but I mentioned the fragmented with the R. So QT, do you guys want me to try and go through QT right now, or do you want to save it for the next time? Anything, anyone? Save it. Okay, so we'll save it for the next time then. And then so next time we're going to go through QT. I'll kind of give you a hint at what I don't want to keep that stuff. Let me share my screen. Just give you a quick idea of what we're going to go over. So we just finished QT. We'll go over QT and then the ST segment, which is the longest section. And then I'll have a bunch of different slides. We're going to go over the benign early repolarization, which has come up multiple times on rounds. How to decide if something's benign or not. Then we're going to go over ST segment pathologic segments. This is where I thought I was going to end. Ha ha ha. And then T waves, we're going to go through the entire T wave segments as well as U waves. We'll go into hypertrophy, R wave progression, voltage. This is where we're going to start seeing the electrical alternans and VFib kind of play a factor. And then I'm going to go over some common EKGs that we'll see that you'll not only see in the clinic, but maybe even on your boards. And then by slide, and then we'll do arrhythmias. This is probably going to be 4 sections, I can already tell. And then eventually we'll get to slide 231. Are there any questions you have on what we talked about today or even last Monday, I think it was? Thank you. Thank you for all the kind comments. I'll take that as no questions. Awesome. If you guys have any that you want to talk to me in person, I'm in clinic all day today as well as tomorrow morning. Glad you all found it helpful, and I will be lecturing. Let me see. So today is the 8th. So my next talk will be Friday. We're going to go over the thrombocytopenia. And then my next talk will be on the 13th on Tuesday. We'll finish up the cardiology diagnostic testing. And then on the 20th, it says TBD on your calendar. That's when I will do my part 3 of this, and I'll find out a later time so I can finish, because I think there will be 4 parts. But again, please come and see me if you have any specific questions. Thank you for your attention, and I'll see you all later.